2, 3.
Welcome. Charcot-Marie-Tooth Disease actually has nothing to do with the teeth. The disease is named after the physicians who discovered it, and it is the most common inherited peripheral nerve disorder known. About 1 in 2,500 people in the U.S. have this disease, and it occurs in all racial and ethnic groups. It's caused by an inherited mutation in genes that produce proteins that support the axons and myelin sheath of the peripheral nerves. This causes our peripheral nerves to degenerate, resulting in poor communication with areas of the body that these nerves serve. The pattern of inheritance can be autosomal dominant, autosomal recessive, or X-linked dominant. In some cases, some rare cases, the mutation is spontaneous and does not come from a family member. This disease is progressive and usually starts presenting itself in adolescence. There are some rare forms that start in infancy, and they tend to be more severe. What is affected in a child with Charcot-Marie-Tooth Disease? It all depends on the severity and how many peripheral nerves are damaged. It can be loss of touch, temperature discrimination, pressure sensation in the hands and feet. We may see weakness and atrophy in the upper and lower extremities. Common deformities are hammer toes, high arches, flat feet, and inverted feet, which can cause difficulty with walking. Possible vision and hearing deficits in more of our severe forms as well. So what areas of occupation are going to be impacted in a child with this disease? Again, it depends on the severity. All basic ADLs can be impacted: health management and maintenance, care of pets, play, leisure, shopping, and education. Precautions. If weakness is present or a child is having difficulty ambulating, we need to make sure the correct safety precautions are in place. We may want to do things like put temperature gauges on hot water heaters if a child has temperature sensation problems. Visual cues for safety when ambulating and also when performing cooking and craft tasks in case they have decreased sensation in their extremities. Treatment interventions commonly used by the occupational therapist would include muscle strength training and endurance training, stretching to prevent contractures, splinting as needed to prevent contractures. Safety education for the child and family are very important, as well as remedial and compensatory techniques for ADLs and IADLs to increase maximal performance. Please see the photos attached to my PowerPoint presentation for pictures of what these deformities may look like in a child. Again, it all depends on the severity. To all of you, thank you for listening, and good luck on your level 2.